My name is Priscilla. I'm a registered nurse. I work for a long-term facility. It's a nursing and rehab facility, and most of our patients are here because they can't take care of themselves at home. They have no families. Some of them are, severely impaired as far as cognition. Others are severely impaired as far as ADLs. They can't, use do the basic things, daily basic things. We take care of, usually they're 65 and older, and most of our end stage Alzheimer's and whatever disease process they have going on. Sometimes they don't have families to take care of themselves at home, or they can't manage the medication, so we're here to provide guidance. Most of our residents that are here, eventually they get to a point where we as an interdisciplinary team, we get together and the doctor is involved, and we talk about their goals and whether or not they're in their end of life. So once that's achieved with the whole team, we approach the family with the approach to educate the family on hospice. We want to find out first what they want for their family members, whether or not they want to be aggressive with care, whether or not they think they have a chance to get better for some reason. So once that's established with the family, we introduce hospice, and most of the time families are not very well informed about hospice. They have a different idea, so we have to be very careful when we approach them with that subject, because they automatically think in death in their, and hospice is just the way they approach care, nothing aggressive. So with palliative care, so whether or not they it doesn't mean that they're gonna die in 3 months, 6 months. It's just the approach we're gonna take, and once they reach that 6 months, hospice is always also reevaluating their residents to see if they still meet the criteria for hospice.
Okay. So have you approached family members that the interdisciplinary team approach them about hospice, and the patient is end of life at this time, that they actually have said no to hospice?
So as I mentioned before, most of families, they're not informed. So a million times I have said no, but we don't want them to die, and we have to explain, like I mentioned before, what hospice is, what are the approaches, what other service they offer. So once that's established, they have the family. Sometimes the family is a big family. They all have a different view of how they want to
pursue death and dying.
Yeah. So sometimes it's religious. Sometimes they say, but who are we to make this decision? God, we don't want hospice because we want to provide CPR, because it's in God's hands and God's decisions. And then we have another family member that says, well, if the heart stops naturally, if isn't that we intervening already on top of God's decision? So we have this family dynamic that we have to consider too. Although sometimes also when the resident is we should always talk to our family members what we want for us when the time comes, because sometimes they're not non-verbal, they're cognitive, they're severely impaired, and they get to a point where they don't know what their family members want for their life, when they get to that point. So it's always good to talk about, with your families what you want. Also, once we speak to the responsible party, although the resident is not responsible for themselves, sometimes families forget to approach the resident directly, because although they're confused, sometimes they're able to tell you what they want. We have, for example, we were having a meeting and we were speaking to the son, and then he said, I have no idea. So I said, well, why don't you approach your mom in a delicate way and ask her what she wants for her, for her end of life. And then he spoke to her, and then she said she wanted everything, to try CPR, a pacemaker, whatever it took, because she wanted to fight until the end. So we have to
How do you think that guilt plays a role in some of the times, like the decision of the family?
Sometimes they're very guilt, depending on what happens, and the fact that they're not able sometimes to have them at home, because we encourage families to, although they have been here for a long time and they consider this their homes, we want to offer the family and encourage to take them to their home so they can, stay with families. And sometimes, unfortunately, the situations, everybody works, nobody's at home, so there is a guilt into having them in hospice. They feel like they haven't done enough, so they want to be sometimes as aggressive as possible. A lot of times too, they're unrealistic of their diagnosis, and we can only encourage and intervene so much as far as educating them on the diagnosis and the progression of the diseases.
A team, approach the family, and hospice is one of the options, and the family member says no. What do you do from there?
With the care and make sure, if the doctor wants to suggest a surgery or whatever, it's more aggressive. It's family wishes. What we also say is the stress that the resident is put on when they go back and forth from the hospital. Sometimes their health is so compromised that you don't want to be back and forth from the hospital. Also, we had a resident that the health was compromised. The brother, said we don't want to do hospice. And after a while being back and forth from the hospital, they decided, okay, this is too much for my sister, so we want to implement hospice. And she was in hospice for a while. So as they reevaluate every resident every 6 months, guess what? The resident was actually better. Sometimes being more holistic and less aggressive, sometimes that's the key. So, yeah.
Thank you so much, Priscilla.
Thank you.
My name is Yolene Virtus. I am a charge nurse in a skilled facility. With the capacity, my unit is 58 patients.
Okay. How long have you worked in this nursing facility?
I've been working for more than 28 years.
Okay. And the 28 years that you've worked in the nursing facility, have you dealt with end of life with hospice and without hospice?
Yes.
Okay. And in your experience of 20-something years, would you say that like how in amount of percentage subjectively, how many people elect hospice in end of life, and how many?
That
Okay, so you have about 25% that doesn't elect.
Positive experience. Because when they're in hospice, when they're deteriorated and the hospice provides a nurse they put them in the crisis care, and they have a nurse with them for 24 hours. We change them, and most of the time, some of them they don't have family who can come anytime, and it's very important. And when the person who's dying and have somebody with the person in the room, who can talk to the person and turn the person position and change the person, give the person backward, and tell the person little story, and they play music with them, and they feel happy because some of them, the families are working, and they cannot be with the patient all the time.
Okay. And the 25% in your unit that does not elect hospice, what are the reasons that they tell you why they don't want to choose hospice at end of life?
Oh, some of them thinks as soon as the person is hospice and you give up and you're not gonna give the patient care. And even we try to tell them when they're hospice and we're still gonna give them care, but some of them think as soon as they're in hospice and they say it's over, there is no more life for them. And most of the time those are the kinds of patients here who die without hospice in the facility.
Because the family thinks that, and that's not true.
It's not true. We give them, they have very nice care, and we still continue the same care with them. And most of the time, the hospice ones provide, the hospice provides helps. Some hospice sends CNAs 3 days and to give them bath and to help them sometimes go outside with them and have a little fresh air with them. And some of them give us full 5 days care with the CNAs and who comes in to help us with hospice, with the patients.
And the people, how aggressive and how, when somebody is elected in hospice, a lot of people, like the family members that you say that does not understand the concept of hospice, how many people in hospice that you see that they give aggressive care except surgery?
Give antibiotic and to treat infections, UTI. Yes, we do that. We give
Okay.
them.
So it's not, so what the family members are thinking is not really.
It's not really. Yeah, they think if the patient gets sicker or thinks we're not gonna do anything with the patient, we're just gonna let the patient die. But it's not that.
Okay. What other barriers do you encounter with family members or responsible parties that decide not to elect hospice at end of life?
Some of them, it's guilt. Sometimes they feel if they make a decision like that for the loving ones or the mother, things like that, and that's the things the mother gonna die in the next day, and they feel guilty for that. And some of them also don't wanna do that because they don't wanna get blamed from the other siblings. Some siblings they want that, some of them don't want. They don't wanna take that decision.
Um, how do you start the conversation in a setting like in a nursing home facility like where you were? How do you introduce the concept of hospice versus not having hospice at end of life? How is that decision made? Where does it start? Where does it come from?
When we try to take the decision for the hospice patients, we have them and they're getting deteriorated. When they're getting deteriorated, some of them been going to the hospital and come back, and some of them have cancer, and sometimes the cancer is spread, and they try to do everything, and they used to get out of bed, and sometimes they refuse, and they're getting deteriorated. We do labs, they go to the hospital, there is nothing we can do, and they don't have the good appetite the way they used to have. Even we put them on medication for appetite stimulant, they're still not getting it. And some of them don't even want to get out of bed anymore. Some of them doesn't want to eat, and the lab are constantly abnormal, and we do everything. And that's the time now we're gonna approach. We have a team, like me as a charge nurse, we there, and the doctors and social worker, dietary. Even we have people sometimes they're involved because patients used to be moved and they're not moving anymore. And sometimes we try to let we have do little exercise and they cannot do it anymore. and we will have a, like I already tell you, dietary doctors and the DON involved also on it. And when we make a decision together, that's the time now, and we will approach the hospice decision with the family member and to let them know what's going on. Them are very happy. Sometimes some of them will say no, and after that, when they really see and we talk to them, and after that they will agree and they're very happy. And I have that going on in my unit now with one of the residents we have here. And they didn't want hospice. Now the patient is on hospice, a nurse next to the patient and giving the patient medication and taking care of the patient and talking with the patient. When they come, they say that they're happy with it. I believe in hospice.
Why?
Because when you are in hospice and you really, there is a certain age when you come like 95 years old, 98 years old, there is nothing you can do. And you are in a skilled facility, people in the skilled facility, giving you love, and you have other people from hospice coming and to give you extra care and give you extra love. That's the reason I really like in crisis care, and they have people with them and they have a nurse with them and to taking care of them. And people cannot die by themselves, and some of them really don't have family who will come. Some of them have families, sometimes they come for a short of times because they have their own families and they have to work, but we there in hospice there with them. I do believe and I like it.
Thank you so much, Yolene.
You're welcome.
Hi, my name is Osvaldo Medina. I'm one of the nursing assessment coordinators in a skilled nursing facility. A combination of services like long-term residents, who are the patients that live here, like long period, generally is considered long-term after 90 days. And then the short terms, which live here 90 days or less, they come usually for rehabilitation after an accident or any other kind of conditions that make them having to live here to receive therapy and skilled nursing treatments.
Okay. So out of those type of population you serve, which one you usually approach with end-of-life services such as hospice? Do you approach it more in the people that are here short-term or the people that are here long-term?
Usually long-term, but yeah, can happen in the short-term too. Some patients come with the idea of short-term and they end up becoming a long-term and even end-of-care life treatment or hospice services. Yes.
In a scale of 100%, of all your patients, a combination of both the long-term and the short-term residents, how many of them elect hospice during end of life, and how many of them, in a percentage, like a subjective percentage, do not elect hospice at end of life?
I will say it's like a combination, like depends, and it also depends, it fluctuates actually, because most of the people, there's a tendency, I don't know, maybe people are learning more or understanding more, but it depends, culture depends, influences, and in percentage, I will say it's not a high percent.
Okay.
It could be a 50% maybe.
Okay.
Maybe to be conservative.
So 50 and 50
Yeah.
on both sides.
Yeah.
For the people that do not elect hospice at end of life, what are the reasons the family members or this responsible party do not elect hospice at end of life?
I think the families think that being in hospice care means the person is eventually or immediately gonna die, it's gonna pass. They think that the services are gonna be different, patients are gonna be like left behind and not being treated accordingly. That's they think that.
So when you encounter this type of barrier, what do you do as a healthcare professional?
Well, we need to make clear to the family what is the objective and the purpose of hospice services. They need to know this is an end-of-life treatment, palliative care, which means we're not going to do aggressive type of interventions, although the basic needed medical care is going to be provided.
Which,
It's gonna
like,
continue.
such as?
Like, let's say a patient with heart problem, we're not going to stop all the medication for the heart or respiratory issues or any other kind of renal issues. We're not going to set up and put the patient to die because the patient is in hospice. We're just not going to do extreme interventions like intubation or
Surgery.
resuscitation like CPR.
And when you have patients in hospice, do you treat like somebody, if the patient gets pneumonia or UTI, is that something that you treat when the
Yeah.
patient is in hospice?
Yes, we're
Okay.
going to treat it.
Okay, good. My other question is, how does the discussion of hospice care introduce to the family members that you have in the facility?
All right, we explain them that hospice is a contract in between an agency that is going to come to our facility to provide the services, and in addition to our services that will
Okay.
still continue providing
Okay.
with our staff. Means the agency staff is going to provide a visit of nurses and assistants, independent of the continue of the condition of the patient. So the patient is gonna become needing a crisis care because it's an extreme or at the end of the dying process. So that these interventions are gonna come more often, and the agency is gonna come here more often with more like aggressive like care, more direct, constant care.
Like a 24-hour
Sure,
type
something
of
like that,
service? Okay. For the people that elect hospice, who pays for that service?
State agencies like Medicaid and Medicare.
Okay.
That'll
So
be
it's
provided.
part of their insurance. And for those people that elected hospice, in general, if you could recall any of your experiences, how is the family's reaction to your residents that passed away with hospice services with them? Like their general.
In general, families tend to accept it once they see how the services are running, and they understand that it's a benefit for the patient that is at the end of life, so this passing is smoothly, comfortable, with less stress for the patient and even for the family. So they see their passing in comfort with no pain, or at least minimized pain.
And how about those family members that do not elect hospice at end of life? What is their general experience from your experience, from your
The
from your observation?
experience, yeah, let's say that you have a family or a patient in an extreme delicate and debilitated physical condition, and you have to do an intervention because legally you need to proceed to resuscitation. It's traumatic for that patient, even for the family, emotionally and physically traumatic, because you have to do extreme interventions in somebody that is actually very sick at the end of life process. Then it's disturbing when they figure out and they see that they did something that was worthless, so like it was not worth it.
In your professional opinion and your professional experience, do you feel that end of life with hospice is more beneficial than end of life without it?
It is, definitely, because you're gonna feel the comfort and the joining in between the family and this person that is passing away. So definitely there's more comfort for that person.
Thank you so much.
Hi, my name is Farah Sylvain, and I work in a skilled nursing facility. We have all type of patient with different age group, varies from 50s to late 90s, and some of them are very sick. They come to us with strokes, end-stage Alzheimer's disease, cancer. Some are here long-term, and some of them are here just for skilled nursing, which is short-term. We send them to therapy, and then when they get to the maximum they will go back home to their family, back to the community.
Okay. And then for the other type of patients that you have, which are the long-term care patients or residents, what services do you provide for them, and what do you do for them in a nursing facility?
We do rehab, physical therapy, occupational therapy, nursing rehab, wound care. We have hospice patients. We have all type of patient. It varies.
But most of the long-term patients live in your facility,
Yes.
and they're there for many, many years.
the majority of them are here.
And
for
why are
long
they there
term.
in your facility?
Some of them had a stroke and they cannot walk. Some of them don't have any family members. They cannot be at home because they are too sick. They have to be in a long-term facility.
Okay, good. How many years have you been a nurse?
I've been a nurse for 14 years this year.
Okay, so in the 14 years, have you worked in this facility for 14 years?
13 years in
13
this
years.
facility.
Okay. In the 13 years that you worked in this facility, have you encountered hospice with end of life?
Yes.
Okay. Are all your patients that encounter end of life, do they all elect hospice?
No. Some families will not want hospice. They don't want to hear the hospice concept because of their conception, the way they perceive hospice.
And then in a scale of 0 to 100%, like in terms of like a percentage, how many of your patients that you take care of elect hospice during end of life, and how many percentage do not elect hospice on end
I would
of
say
life?
now 25% don't want to elect hospice.
Mhm.
And then 75%, of course, they want their family members in hospice after you explain to them
Mhm.
what hospice is all about.
And how do they get to the decision of choosing hospice versus not hospice? Who introduces the concept to them? Explain to me the process.
It's a team effort. Once we realize that the patient declines or their disease is towards the end, we have a family meeting, which is an interdisciplinary team. Social services, nursing, physical therapy, dietary, the doctor. We all meet with the family member to let them know this is what the patient needs
Okay.
to be hospice.
Okay. On those patients that elect hospice, what is the general consensus? Like, how do they feel towards hospice services? Are they unhappy with it? Are they happy? Are they satisfied? They're not satisfied.
Oh, they're very happy. The family
Why
members
is
are
that?
very happy. The first thing that I think is because they have two teams working with the patient. They have the facility team and they have the hospice team that comes outside. So it's like they have two teams that works with the patient, and then once the patient is on crisis care, somebody's there 24 hours with them.
Explain to me what crisis care is.
Crisis care is when death is imminent. We know within 48 hours this patient will die, and we want to keep them comfortable. So somebody will be here next to the patient, make sure the comfort level and the pain level is managed. Like the patient is comfortable.
Like, you mean 24/7?
24/7. Somebody's there with them.
Okay.
Plus, they get our team also. If something that hospice is missing, our team will pick it up.
Okay, good. And you say that the general consensus of the family members that elect hospice
They
for
are
their
happy.
loved ones, they're happy.
Yes.
Do you feel that they're treated with dignity and respect?
Oh, yes, definitely.
Okay. And for the 25% of your patients that do not elect hospice, what are the barriers that you encounter? Why they don't want to elect hospice at end of life?
Because not everybody that goes to hospice will die within 6 months. I've seen patients that comes out of hospice. So their conception of hospice, they don't think that the patient could go to hospice for pain management, for example. So they think, oh no, I'm not going to do hospice because he's not dying yet. That's one of the things that the family member will say to you. No, he's not dying yet, or we don't want hospice. It's just the way they view the conception of the hospice.
But you usually approach the family member or the responsible party about hospice when there is an end stage type of diagnosis, correct?
Yes.
Okay, so that is a criteria. And what other barriers aside from just the misconception of hospice altogether? are there any other, from your personal, from your professional experience as a nurse, are there any other barriers that you think of?
Sometimes the family member feels like if they put the patient on hospice, they will feel guilty.
Okay.
It's guilt also has
Okay.
something to do with it.
Do you feel that maybe family members have unrealistic goals
Yes.
of the disease process of their
Yes.
loved ones?
They in denial.
Okay.
They don't think the patient is going anywhere yet. So why do we need to do hospice?
Okay. And in general, those patients that pass away without hospice services, how do you think the perception of the family is in terms of like the end of life?
They still happy because our team, which is the nursing facilities team, we still do take care of them. We call the doctor if we see the patient is in pain. We manage it also.
But you have to send the patient to the hospital
Yes.
in and out. That's the
Yes.
only thing.
Yeah, they go in and out of the hospital because there's certain things that we cannot do here. We have to send them
Okay.
to.
And do you feel that's beneficial for the patient?
No, it's not.
Why?
Because sometimes the patient is very sick. There's really nothing you could do.
Mhm.
You know they're gonna die and they suffer. Compared to if they had hospice, they could have had somebody there with them to manage their pain better, more effectively,
And their symptoms.
and then their symptoms, and also to keep them comfortable.
Okay. So for in your professional end of life with hospice or without hospice?
With hospice.